Today we're doing the first part of a two-part series for insulin resistance and diabetes. So it's setting the stage a little bit. I purposefully made this a little bit shorter so we could go over questions that might come up. Here we go. Okay. And could I see some feedback? Can you all see this? Yes, okay. Thank you. Thanks for the hand raises. Okay, well, nice to be here with you all on Wednesday, Wellness Wednesday, as I like to call it. So today we're talking about diabetes and insulin resistance. Those of you that have been to previous seminars or webinars that Jay and I have had, you've heard this topic before because it's such a big piece in the pathogenesis of a number of different disease states that we talk about. So what you don't know can hurt you. To start, let me see if I can hide this here. But to start, we'll go over a few questions. So the first one, do you have insulin resistance? You can answer these quietly. But the first one, do you have insulin resistance yourself? Do you know? The second, can you have insulin resistance if you are normal weight? The third, is your lifestyle promoting insulin resistance? And the last one, what conditions are associated with insulin resistance? So these questions are really just to get us thinking, to be engaged in the rest of our presentation. So do you have insulin resistance? Well, let's check it out, right? Some people already know they do, and a huge majority of people that have insulin resistance do not know that they do. Yes, you can have insulin resistance if you are normal weight. You can have insulin resistance if you are underweight. It doesn't always go with weight, although there is a very strong correlation between insulin resistance and overweight in particular and obesity. Is your lifestyle promoting insulin resistance? That's another big piece that we'll check it out. And as far as conditions that are associated with insulin resistance, there are so many, it is difficult to name them all. I put a few here. Fatty liver, PCOS is polycystic ovarian syndrome. That's becoming more and more common nowadays. Dementia is associated with insulin resistance, heart disease, obesity, amongst many others. Okay. The who, what, and where. So what are we talking about? Let's go through a couple of definitions. So first thing about diabetes and prediabetes, about 1 in 3 of us in our country has prediabetes. That's a huge number, right? 1 in every 3 of us. So if you think about, we still don't get together in big groups, right? But if you're in a group of 12 people, that means 4 are going to have prediabetes. 88 million Americans. And the most concerning piece of that is that 90% of people do not know that they even have it. 34 million people are living with type 2 diabetes. So, and I left in here also a little info on the 72% of us. So 2/3 of us are overweight or our weights fall in the obese categories. So I've left that in there because there's such a strong correlation again, because if we do have any excess tissue, those fat cells don't just sit there and irritate a lot of people. A lot of people seem to be irritated by them. They don't just sit there and do that. They actually are metabolically active and they're secreting hormones, they're changing hormones, they're causing insulin resistance themselves. Okay, so definitions of diabetes. So this, I like this slide because, it goes over the very critical definition here of type 1 versus type 2 diabetes. We're not getting into it today, but there are many other types of diabetes, steroid-induced diabetes, gestational diabetes that women can get when they're pregnant, MODY, or all these other diabetes that are more rare. This is specifically calling out what happens in a healthy body versus type 1 versus type 2. Okay, so if you all can see my cursor here, So this yellow thing here, this is a depiction of the pancreas, and this is a depiction of the small bowel. Okay, so the pancreas has a couple jobs. One is to make hormones that will help break down the food that's going through the small bowel. Really cool how it works, but it secretes those hormones out here. It helps you break down food. Okay, so that's one piece of it. The piece that we're talking about today is more of the activity that happens on the tail here, and that's secreting hormones into the blood. The hormone we're talking about today is insulin. Insulin helps get the sugar molecule to go into the cell. So if you have a meal, you have more sugar molecules or glucose. You have the sugar that goes into your body, into your bloodstream. You need help to get that sugar into the cells where it can be utilized. If you do not have insulin, you don't have a way for that sugar to be taken up into the cell, okay? So type 1 diabetes, the problem with type 1 diabetes with this disease is that the body does not make insulin. So since there's a failure to make insulin, when you have sugar in the body, you eat, you have your meal, lunch, let's say, since it's lunchtime, you have lunch, but there's no insulin there to get it into the cells. So this awful situation where you have very high sugar levels, but yet your cells are starving. They need energy. Type 1 diabetes, you must treat with insulin. That's the part that's missing. You must treat with insulin. That's the only treatment. Type 2 diabetes is 93% of the diabetes that we see nowadays. And this is what we're going to focus on today. So type 2 diabetes is insulin resistance. So the pancreas pushes out insulin. And in fact, it usually pushes out a lot of insulin. And the whole goal, this is the body working very well and very hard to try to make up from excess sugar coming in to the bloodstream via our diet. Okay, so let's say at lunchtime, we have lunch, we have the sugar or the glucose coming into our body. The pancreas is pushing out insulin, but after years and years of pushing out insulin, large amounts, the body stops responding to the very high insulin levels. It's almost like a coach yelling at a team. If a coach yells all the time, people stop responding as much, right? It's that quiet coach that very rarely raises his voice. And once in a while, when he or she does, the team responds, right? So if in the type 2 diabetes scenario, we're having large amounts of sugar come in via the diet all the time, and that forces the high insulin levels, the body gets sick of always responding like it's an emergency. So it stops responding to the insulin. Then the body's only mechanism is to make more and more and more insulin to try to get the body to respond. Okay, so type 2 diabetes, it's not that there's no insulin. There's a huge amount of insulin, quite commonly. The problem is the body's no longer responding. We call that insulin resistance. Oh, I apologize. This is a little blurry. So this is another definition slide. And this is the definitions of diabetes, prediabetes, or the normal range of blood sugars. So there are multiple ways, 3 ways in particular, that we test for and diagnose prediabetes or diabetes. So the first or the middle one here is the one that's been around the longest. So let's focus on this column here. So normal blood sugar is less than 100 if someone's not eating. Okay, so if someone's fasting, they had dinner the night before, they go to bed, when they wake up and we check sugar levels on lab work, the sugar level should be less than 100. If that sugar level is over 125, that's the definition of diabetes. If it's somewhere in the middle, like 100 to 125, that's prediabetes. Okay, so this is just pure definition. The A1C is a newer way to check and to monitor sugars. It works better for monitoring someone's blood sugar level when they have diabetes. It's not as accurate to diagnose diabetes, okay? If we're using A1C alone to diagnose diabetes, it's going to miss the diagnosis 30% of the time. The fasting blood sugar is better to diagnose diabetes than A1C, okay? The oral glucose tolerance test is even better than the fasting sugar. So this A1C level, so if it's written correctly here, it would actually read out saying hemoglobin A1C. Hemoglobin is what we call the red blood cells in our body. So the hemoglobin A1C got its name because we literally are checking to see the amount of excess sugar that has gotten stuck onto the red blood cells. If someone has high blood sugar levels in their body, the sugars are found everywhere, including on these red blood cells. So when we check how much excess sugar is stuck onto the red blood cells, normal is about 5 in this reading. But if someone has pre-diabetes, we see that's elevated, so 5.7 to 6.4. If it's 6.5 or above, then by definition, that is diabetes. Then this third one, this oral glucose tolerance test. I love this test. It's fantastic. The best way to do it, we can actually do it nowadays with checking insulin as well. And that's the absolute very best test. There's not too many of us that have been doing that, although it's more and more docs are going that way. So this is what it is. So someone goes into, if any female has had a baby, they have probably gone through this test because this is what is done when someone's pregnant to see if someone has an issue with blood sugar. Since it's the most sensitive, this is the one we use during pregnancy. So what happens is someone goes into the lab fasting first thing in the morning, typically, and their blood sugar is drawn. So that's the first step. That's the initial blood sugar level. That's your fasting. Okay. Then the person is given a drink of like pretty much pure sugar water. So they need to drink that. 2 hours later, we check their blood sugar level, and these are the ranges. So if it's less than 140, that's normal. If it's 200 or above, that's diabetes. If it's somewhere in between, it's pre-diabetes. So again, just pure definition, okay? The insulin level, if we tack that onto the oral glucose tolerance test, that's another test, and I'll get into that a little bit later. We don't use that insulin level to diagnose diabetes, although oftentimes it tells us if the person has a problem with insulin resistance, and it can tell us that up to a decade before we see any changes in the sugar level. So one of the questions at the beginning, is your lifestyle promoting insulin resistance? We can tell that. Actually, we can usually tell it just by asking the patient, what are you eating? How are you exercising? Are you getting enough sleep? Do you have a lot of stress? Those questions, but also by that oral glucose tolerance test with insulin. Okay. This is probably my favorite slide. So this is one for us to start to get into. I want us to get used to taking a look at these graphs. It gets into a little bit more of starches, which we'll talk about further down. Okay, so let me orient you first, please. So on the y-axis here, we're talking about sugar levels. You don't need to pay attention to the numbers in particular, but sugar levels. So the higher we go, the higher your sugar level. And then on the x-axis, we're looking at time of the day, so in a 24-hour time frame, okay? So you'll see these arrows at the bottom where it says breakfast, lunch, dinner, and then this time is when we're sleeping. So we're looking at both the glucose sugar blood levels and the insulin blood levels, okay? So let's walk through together the glucose first. So we're having breakfast, and we're looking at the solid lines first. We have breakfast, so we have this intake of food into our system, made up of sugars or whatever else we'd have for breakfast. Okay, so the sugar level, the glucose, we see a spike in that because sugar is going into our body when it's absorbed from the stomach. We see a spike of that. Your body says, hey, we need some insulin to help bring down the sugar level. And then this blue level down here, this insulin level spikes as well, okay? Then the meal is taken care of. We've gotten the sugar that's come into the bloodstream. We've pushed all the sugar into the cells, good to go. So sugar level goes down and your body stops producing the insulin because it doesn't need it anymore. So then it comes back down, okay? So then insulin really tapers down because again, it's not needed. Then comes lunch. So then we have lunch going to the body, sugar level spikes as we'd expect, insulin level spikes as we'd expect, and then it comes back down afterwards, okay? And then dinner, same thing, sugar level spikes, insulin level spikes, okay? A couple things are the piece to call out that's so interesting and so well described on this graph is the part here when we're talking about starch-rich food or sucrose-rich food, okay? So instead of these terms that people don't know what we're talking about, we can, where it says starch-rich food, we can say like potato or real food, you know, long grain rice or barley, buckwheat, beans, anything that's like a real food, okay, non-processed. That's the solid line. The dotted line, sucrose-rich food, we would say processed. So this would be like a box of cereal, pre-made meal, that type of thing. So things that are highly processed and don't have as much fiber, okay? So right in here where we have lunch, let's say someone has a crummy lunch and not a very healthful lunch. What we see is, okay, those sugar levels go higher than what's normal. Like this is not physiologic, this is not normal. The human body is not used to highly processed food, okay? We're not designed that way, we're designed so many years ago. So we see this extra large spike in the sugar levels. So then your body has to work really hard to push out extra insulin in order to respond to that high sugar level. It responds, but oftentimes what we see is it over responds. And then we see the sugar level drops. So if you can see down here, the insulin level and sugar level go really high and then boom, down. This is not normal to have a sugar drop this low. So as this graph shows, the mid-morning lull or mid-afternoon lull, some patients feel this, but I'm not even kidding, after every meal. And it's awful. So this is how it comes about in the office, is people come in and they describe episodes of dizziness or, wow, like I need to eat right now. Yes, you do, because your body's sugar level is very abnormally low. But that's not due to any medication or any other pill. That's literally due to the very processed foods that we're putting in our body. Okay, then it comes back up in response. So this same thing, it's just, this is my own little depiction, but we want to be on this green line, right? This is what the body can tolerate. Just gentle ups and downs, ups and downs. So breakfast, lunch, dinner, but little ones. That's how we're designed and how the human body works and can work for many, many years. If we're doing this, where we're having these huge swings up and down, we're not made like that. And that's where we see the body peter out and dis-ease comes about, disease. Okay, so how does that develop? We got into that a bit just already. And you all might have seen this before, but insulin resistance. So someone has is a very highly processed meal. Then we get the high sugar level coming into the blood. That causes the high demand for insulin. So you have a lot of insulin and a lot of sugar to get the sugars into the cells. And then shortly after that, you get starving cells. You get in the high sugar, high insulin level, create more hunger and cravings. So, and this is the cycle over and over and over. So this one, I promise we won't get too into the weeds because that's not what's helpful for people, but just to understand it a little bit, because this is the tie to fatty liver, also fatty muscle that we talk about a little bit less, but the disease process is the same. So this is what happens. So dietary fat comes in, because thus far we've just talked about sugar. Dietary fat comes in, and then you have this in the fatty acids in the liver. So we eat food. The first place that blood is taken is to the liver to help detoxify, okay? The liver tries to help by trying to get some of that fat out of the bloodstream and pull it into itself. So we start to see fatty liver formed that way, just literally pulling out the fat that we just put into our body via our diet, okay? When the liver starts to have a bunch of fat cells collected inside of it, what we can see is fatty liver, and then the liver can't function quite as well. We get insulin resistance. Then we get the high insulin levels and the high sugar levels. That stimulates more formation of fat, and that stimulates more fatty liver. So then it's this bad cycle we're going in. The insulin resistance also creates any fat tissue to break down and create more free fatty acids from that fat tissue. And again, that stimulates more fatty acids in the liver and more fatty liver. Okay, so complications. So if there is anything to take away from today, one of the things that would be very helpful would be to the complications of diabetes. We don't talk about that enough. I know people think, oh, some people have that, but no, it's not just some people. It's our neighbor, it's our family member. I mean, it's very close, right? It's 1 in 3 of us that have pre-diabetes. So complications of diabetes. So with diabetes, we have very high sugar levels and insulin levels in the bloodstream. Okay, that's inside the blood vessels. So where we see the damage first is typically in the smallest blood vessels. So that's in the blood vessels of the eye, where we see retinopathy. It's just a fancy term to say like damage to the retina and blindness. So damage to the eye. The other very small blood vessels are those in the kidneys. So we see kidney damage that can worsen and go on dialysis. If someone's on dialysis, they're commonly go to the dialysis centers. It's 4 hours, 3 days a week. Very tiring. People learn to live with it, and it's great, much better than the alternative. But most people would absolutely choose to not do that unless they absolutely had to. Or the blood vessels that supply the nerves. So the longest nerves of the body are the ones that go to our very tippy, the toes, the very longest nerves in our body. And those nerves can get irritated first because they're supplied with blood vessels. Those tiny, tiny little blood vessels supplying the nerves get damaged first, and we get neuropathy, where people can't feel their feet, or the beginnings of that are like numbness and tingling on the feet. It's really irritating, especially at night. Patients. Then other things, the diabetic foot infections, because people can't feel their feet as well, and there's not as much good blood flow there. Excuse me. And then we call it macrovascular disease, but the larger blood vessels are the ones that cause heart attack or dementia. Okay. So the causes of disease, I know some of you on here, I know you've probably heard this over and over, but it's low fiber and highly processed foods. The reason low fiber is because when food is in the stomach and it gets absorbed into the body, if there's a meal that goes in and it does not have very much fiber in it, that gets absorbed very quickly. It's easy for your body to absorb that, kind of like a sugar cube. You know, when you put water on it and it just dissolves really easily, or a donut or other things that are really highly processed, it's very easy to make them dissolve, as opposed to something that's like has a lot of fiber in it. So wild rice, for instance, you have to chew that a lot before you can eat it, right? It doesn't dissolve really easily. So the lower fiber foods are absorbed quicker and cause higher and quicker spikes in your blood sugar. Lack of activity. causes insulin resistance. Lack of sleep causes insulin resistance. Stress does via the mechanisms of if someone is stressed, is chronically stressed in particular, our stress hormone goes up. If our stress hormone goes up, the body doesn't know if it's running from a lion or if it's just that my husband made me so mad. So the body needs to prepare from if it's the lion, and it's going to make sure your sugar level is up a little bit so that you can book it if you need to. So if we're under chronic stress, we see the sugar levels rise because that's a survival mechanism of the human body. And then overweight or obesity, because those fat cells are sitting there and metabolically active. They're changing the hormones in our body. Okay, so I included this slide, the check yourself. It's actually a really good process to go through. The next few slides will be talking about diet. And with myself, with my patients, quite commonly we think, oh yeah, no, we have a good diet, but sometimes it slides a little bit and then it slides a little more. And then once in a while we have to take a look and say, hey, wait, I actually am not eating as many greens as I thought, or I'm not getting whatever it is that's maybe fallen off the diet a little bit. So please, it's a good lesson and activity to go through and say, hey, wait, am I actually doing what I think I'm doing on a daily basis? 75% of Americans say they eat healthy, but more than 80% of us fail to eat even the basic recommended amounts of fruits and vegetables. And our recommendations are not as good as they even should be. So if more than 80% of us are not getting that, but 75% of it, and so only 20% of people are actually getting the fruits and vegetables that our bodies are needing, but 75% of us think that we're eating healthy. There's a disconnect here. So again, a good reason for us to take a step back and take a look at our diets. So the plant-based plate. So this one, again, I have to give credit to Kaiser here, but this is such a great picture of what our plates, what an ideal plate would look like. A quarter with protein, plant-based protein. So that means not inflammatory, lots of nice fiber and different other cancer-fighting compounds. A quarter of the plate with either starchy vegetables or whole grains. And then a good half the plate with vegetables. In my favorite slide. So this, there are two ways to check yourself in kind of an easy fashion. One is when you're sitting down to eat, just kind of glancing at your plate and being, yep, this is what my plate looks like, good to go. Or sometimes it's easier to take a day and say, okay, what is it that I had today? Did I get my base? Like most of what I was eating today was vegetables, and then other combinations of fruits, legumes, so beans, lentils, and peas, whole grains, nuts, seeds, and avocados. Is this what I was getting today? And if so, fantastic. And then the others, very, very sparingly, if we do eat them. Good. Another way to check ourselves, just because it's very easy to slide of getting a little bit more of the processed plant foods in, or a little bit more processed food than we intend. I've noticed more and more with patients in the office that we'll start out hardcore, like really getting good foods, and then slowly, in life and things get busy, or we get in habits that it might not be the most healthful, and just a little correction really changes hugely the trajectory of our health. Okay, so what about keto? I'll suffice it in a couple, just in this slide here. So with the keto diet, what we can see is that people's blood sugars look fine, right? They look perfectly great. In fact, oftentimes if people are on the standard American diet and they go to the keto diet, the blood sugar drops significantly because you are not eating any sugar. It will do that. It can produce low blood sugars, controlled blood sugars in the short term. The problem comes from the insulin resistance that's caused from the keto diet Where long-term, the longer someone's on the keto diet, the more and more and more insulin resistant they become. So when we look at this graph, the keto diet is up here, the eggs, oil, fish, this is a lot of what's had on that diet. Or if people do dirty keto, then even some of the cheese and other processed meats and that I would absolutely not recommend since they are class 1 carcinogens. So what happens is, again, the sugar levels can look good short term, but in the long term, we're causing more of the underlying problem, which is the insulin resistance. So if we really look at treating the root cause, we want to focus on addressing the insulin resistance, not addressing the blood sugars being high. This sounds kind of funny, but it is true that diabetes and high sugar levels, that is a symptom of a bad diet, right? The bad diet is the problem. The symptom is the high sugar levels. So if we're just treating a symptom, we're going to be spinning our wheels. We're not getting anywhere, right? We need to address the root cause of the problem if we want to really make progress. Okay. So how to address it? To the unhealthy weight, yes, addressing that takes a little bit longer. The shorter term is usually the diet, as we talked about. I wanted to go over a few other additional info. This is a graph that you all might have seen. No joke, this is what I was taught in medical school. So what, 15 years ago now? This is the kind of graph that I had seen. So it used to be, I want to make sure everyone sees this, okay? This is old school. This is not what we know now. In the past, this is what was taught of the blood sugars with carbohydrates going up. Okay, this is the fallacy with this. And I'm bringing it up because you all might see this here and there and then get kind of confused of, okay, well, why is Dr. Cox saying something and yet this graph is so obvious? Well, this is true if you're talking about processed carbohydrates. But a carbohydrate is not a carbohydrate, right? I mean, a lollipop is a carbohydrate, and so is a piece of broccoli. Black beans are carbohydrates, and so is white rice. So just lumping it together as carbohydrate, that's inaccurate. And in fact, if you want to make this graph accurate, you really need to put in front of carbohydrate ultra processed carbohydrates, which are a lot of what's found now. You actually oftentimes have to work hard to get the real food. So, okay, a couple call outs on medications that we use to treat diabetes. Metformin, it's the first line medication. We've been using it the longest, very effective as far as helping with insulin resistance. How does it work? It works by making your body more insulin sensitive. It actually works in a few different manners. But increasing insulin sensitivity is the main way that it works. The other thing that increases insulin sensitivity is walking. So when patients see me, if they have a new diagnosis and they don't want to be on medications, okay, metformin is one option. The other option is to go for walks. To get the biggest bang for a buck, it would be going for a 20-minute walk after each meal, because that's when you see that spike. Making sure we get the insulin resistance, the insulin sensitivity, like you're having your body respond to that insulin that's there when it needs it. The biggest bang for a buck is the 20 minutes right after eating the 2 or 3 meals that you have a day, or one, it depends person to person. If you only have 1 meal a day, please go for longer than a 20-minute walk. The other one to call out, we've had a lot of patients ask us about these medications because they're on commercials a lot. So as far as do they work? Yes, they can work. Okay, so they do work is what I should say. Ozempic, Fructose, these ones are medications, medications that we use for diabetes, or under different names, they're also used for weight loss. Okay, so they're indicated to be used if someone has diabetes, high sugar levels, or if they have obesity, high weight. the way in which these work is that it causes the food, after you have a meal, it causes the food to stay in the stomach longer so that your body absorbs the sugar from the food, it absorbs it slower. So instead of causing a big insulin spike, it just slowly goes up, okay? That is exactly what fiber does when you eat fiber in the diet. So I very often, I think probably every single time I've ever had this conversation with patients, I tell them, yes, this is an option. The other thing we can do is, instead of giving you this very expensive medication that they would have to pay for, instead of that, we can just increase the fiber in your diet and have that same effect. It works also, it changes another hormone level in your body, which is also changed by that increased fiber in the diet. So it has people feel full longer, the blood sugars go up more physiologic and slowly, and that's how the weight loss comes about as well. So the takeaways from today, so how to prevent, treat, reverse type 2 diabetes or insulin resistance. Eat high fiber foods. That doesn't mean a fiber pill or like fiber 1 bars or that type of thing with the added fiber. That can give people a lot of bloating and gas. Please skip that and just go for the real food. Fiber is only found in plant foods, so vegetables, fruits, legumes, so that's beans, lentils, peas, or whole grains, nuts and seeds. So eat high fiber foods, exercise after meals, and get plenty of sleep. I didn't comment on it, but to add in here, sleep. Why do I mention sleep? If we're chronically sleep deprived, our insulin levels go up and it stays up all day. So getting plenty of sleep is critical to bring down the insulin levels. Actually, quite commonly in the office, if there's someone that's dealing, if we see that there is high sugar level, one of the biggest questions we ask is, how is your sleep? If you're not getting enough sleep, let's talk about that before we get into the weeds about the diet, because we've got to get the sleep down. Okay, that's what I have. I see a couple of questions here, so I'll give the ball back to Jay.
Hi there, that was wonderful, really, really excellent. So really good information. Right off the bat, we're asking here for a clarification. So please explain why keto, high in protein, promotes insulin resistance. One quick point though, the true keto diet is very high in fat, but protein, high in animal protein, also promotes insulin resistance. Could you talk about that just a little bit?
Yes, so keto diet by definition is 70% fat is like keto. So that's the one that really is high as far as promoting insulin resistance. Animal proteins are not healthful in large amounts for multiple reasons. And actually, Jay, if you want to talk about that a little bit more, you seem to explain it very well. So if you want to, or I'll take it.
No, sure. So it's really, really interesting. It's a little bit of a long and complicated story, but our bodies manage plant-based proteins so much better than they do animal. So as Dr. Cox said, there are myriad reasons why we want to avoid animal proteins. It creates inflammation, clogs our arteries, does all of those things that we want to avoid. All of those things contribute. All those things contribute to overall unhealthiness, right? And damage to the body. We want to make sure that our body is functioning well. Our systems are not separated. They are all connected. And when it comes to animal proteins, there are studies that show that the animal proteins actually raise blood sugar, but what happens is they raise it later. And this same thing can happen with non-nutritive sweeteners or 0 calorie or low calorie sweeteners. They don't spike right away. They tend to spike, maybe an hour or so later. And the same thing can be shown in studies with animal protein. So we're getting those spikes, and plus animal protein almost without fail contains high saturated fat, high cholesterol, and we know that the fat does contribute to that insulin resistance.
And the other thing to add, thank you so much, Jay. When I've heard you explain it before, it's so clear, just like today. So the other piece too is that it's devoid of fiber. So you're not getting the physiologic, nice, gentle dripping into the bloodstream of the sugar levels. So the protein is a protein is a protein as far as your body needs them. I describe it a lot to people like Legos, right? Like you need the little different pieces of Legos to build something. You don't care where it comes from, right? You just need those parts. That's how the body responds to the amino acids, to the actual proteins that we need to build muscles. So if we get it from a package that's very inflammatory and that causes more inflammation in the body will raise sugar levels, insulin levels, and contribute to chronic disease. Do we want it like that, packaged with cholesterol and no fiber, or do we want it packaged with foods that are very anti-inflammatory? So.
Yes, it's very much the way that our digestion works. Our body understands how to digest foods that come in their package with their fiber. And it gets really confused otherwise. I say confused, they just digest inappropriately. It absorbs in the wrong spot, and it causes those spikes. So, okay, so we have a few questions here. Would insulin resistance cause extremely and constant cold feet and fingers?
That's a good question. So it should not on the typical. And I'm hesitating because do you remember that graph where we saw, if someone has a processed food and there's an extra big spike in the sugar levels in the insulin, and then there's a drop. So then they have really low blood sugar or they're feeling crummy. At that point, like people can describe different symptoms of that because your body's kind of, I need sugar. So people can have symptoms at that point, but not typically constant cold feet or fingers.
I just wanted to make one little comment as I was thinking, watching you and looking at your slide, that hangry feeling when you get extremely irritable, where you feel a little sick and shaky and terrible after you eat, that is that extreme drop in blood sugar. That's what that's doing to you. It's not that, that you have a problem with the way that you manage. It is that what foods that you're eating. So, okay, another one here. Oh, I just wanted to point out that Rebecca mentioned that her daughter has insulin resistance and was diagnosed at the age of 10 years old. My goodness. So that's something that she's been dealing with. Debbie asks, could peripheral neuropathy be mistaken and be caused by back problems?
That's a good question. So we do see neuropathy caused by back problems. So this is how we can tell more if it's back related or if it's a systemic issue like diabetes causing it. So typical peripheral neuropathy caused by diabetes is, again, the very tippy top, like the longest nerves. So the toes. So we start there, and then the forefoot, like the beginning of that foot, or the furthest away, closest to the toes, that we have symptoms there. And it's usually on both sides, and it's like across the way, so of those toes, okay? So both sides at the very distal part, like the tippy top of the toes. Something with a back problem is more commonly on one side. And sometimes it can come and go. If it's there all the time, then the distribution and like where people feel symptoms is not always on the tippy top of the toes. Sometimes it's more on one side of the foot or even a side of a calf, something like that. So definitely your doctor would be keeping an eye out for that. But the back issues are not typically on both sides, or at least they don't show up at the same time.
Great. Rebecca asked, if a person has insulin resistance, should that person have their liver checked for fatty liver?
That's a good question. So the answer is there fatty liver present? Do we need to look into it to treat it, right? So we can check for fatty liver. I'm kind of him-hawing around this one too, because we can test a myriad of different things, right? But it won't be until we start addressing the treatment that then we'll have improvement. So the treatment for insulin resistance and the treatment for fatty liver are both going to be the same. If someone does the treatment, then the treatment as in addressing the nutrition, regular exercise, getting sleep, not having too much stress, then it will improve both those. So it's up to you, Rebecca, as far as the individual with your doctor, if you want to proceed with more and more testing, or if you want to focus all your attention on the treatment part of it. Going through a bunch of tests can be really cumbersome for people. Usually I'll recommend like, hey, let's really focus on the treatment, unless there's concern that there might be scarring or some long-term damage that we really need to address right now with the liver. Does that make sense? Or is that clear?
It was to me. Rebecca, ask more questions if you need to. Feel free to keep popping in questions in the Q&A and chat. We have a few more to go through, but hopefully we'll be able to get through. We have another 9 minutes. She says, yes, clear, thank you. Okay, Patrick asks, my primary doc moved me off metformin because of the raise of creatinine levels and moved me to glipizide. Does it work the same as metformin?
Oh, that's a good question. So it works similar. Glipizide is one of the older medications. This is one where it's if your creatinine is raising, then there are concerns with being on metformin if your creatinine is over a certain level. So it used to be 1.3, but now it's 1.4 or 1.5. So if the creatinine is elevating and your doc moves you to another med, glipizide is an option. It's an option that a lot of us used to use in the past more. There are newer medications out there that can be more helpful. I'm kind of dancing around to, I guess I am all the questions today, apologies. But as far as does it work the same as metformin, there are a number of things that are similar as far as how it works with metformin. Yeah, it's a lot more concerning as far as the ability is lowering your blood sugar levels too low, whereas metformin cannot, or theoretically does not. And some of the newer meds, it might be worthwhile to have a conversation about would one of those be more helpful than the glipizide. There have been some more concerning reports coming out about the glipizide. We still use it, but not as first line as we used to.
So would it be fair to say that it's really important that to recognize that each person's diagnosis is an individual and unique experience, and that your care must be customized to you?
Yes, 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 yes.
Okay. So we have a question here about, is there a good, and by that I mean easy, way to track fiber intake? That's from Barbara.
That's a good question, Barbara. So I like, I always say it different than Jay does, but
Chronometer.
Yes, and usually I'll flat out tell people, like, don't plan on doing it every day because it'll make them crazy. Like, just choose a couple, 2-3 days and put in what you had. But it has a really good calculator to see how much fiber is in there. So at least just, again, a way to check yourself, right? To put it in the chronometer here or there and, oh yeah, I got like 56 grams today. I guess I'm pretty good. So, but yeah, that one, if you find that easy enough, I think that was the easiest for people.
I also have a really cool tool that I like to use that can be not as accurate, about 90% accurate, but really, really easy. Give me a call if you're interested in checking that out. Okay, so Elaine asks, I have a broken toe. What exercise would be effective after meals? Instead of walking, I'm assuming.
So this, yeah, so really anything that would get your heart rate up a little bit. So if you could bike, if your doc says, not biking, no biking right now, if they say that for some reason, then, even just kind of dancing around in the chair or something to get your heart rate going a bit.
Right. Yes, very clear. Okay. Linda asks, how is fatty liver identified?
That's a good question. So a lot of times we'll see that liver enzymes are a little elevated on blood work, and then that will stimulate us to order an ultrasound. Ultrasound is the best way to diagnose fatty liver, better than CT or other modalities. So like imaging studies. So ultrasound is the answer. There is a better scan to be able to quantify how much is fat, how much is maybe scar tissue in there, if there is any. That's a fibro scan, but we don't usually jump to that. Ultrasound's the first.
Can you briefly discuss what a healthy liver looks like and what a fatty liver looks like? if you were to look at it?
Yeah, so fatty liver or healthy liver, if you were to look like it looks like, this is something I should be, it's very smooth. So you touch it, it's very smooth. It's pretty firm, but it's almost like when you rub your hand down your back, right? It's firm, but smooth. So that's a healthy liver. A fatty liver, it looks like and feels like it's been filled with butter, honestly. So, and it's, when you push on it, it's squishy. You can put your fingers in it and remove your fingers, and the finger will still indent into that liver after you've removed your hand. It's enlarged, but it really does, it looks like there's butter inside there. It's yellowish quite commonly because of seeing the fat too.
If you're into that sort of thing, it looks really, really cool to see the difference. And it's a good motivator to stay on track with your health. If you're into that sort of thing, if you're not, then don't do it. It'll gross you up. Can you, sorry, go ahead.
Oh, I just wanted to interrupt 1 minute just to say for Patrick, you know, you had asked about the glipizide. The most appropriate way I should have answered that was to make sure you talk with your doctor.
Yes. Yeah.
I know you jumped in there, Jay, but
no worries. That was an important little say there. So there was, you know, when you were looking at your slides, fantastic slides. I just love them. There was a mention of fructose, and I really like to clarify this because some people get scared about fruit. Can you explain the difference about fructose and fruit?
Yeah, actually, do you want to explain it? Because that's another one.
Sure. So yes, there is fructose in fruit, but when you eat fructose that has been processed, that's been separated from its fiber, again, fructose is not the problem. It is isolated fructose. So when you eat your fruit, the sugar that's found there, remember, sugar is such a dirty word, but remember that that energy that your body needs is in those whole carbohydrate foods. So it's not fructose that's the problem, it's fructose that's been separated from its source.
It's similar to, like, if someone has an orange, you know, you eat the whole orange with the fiber, that's not going to cause this blood sugar spike. It causes a physiologic response. If you have orange juice, now you've separated out again. Yep.
Absolutely. Can you tell us just a little bit about type 1.5? That's one that we're kind of seeing a little bit more these days.
Yeah, so that one's one where I didn't put it in here because it can be confusing to people. It can be confusing to docs even, including myself sometimes when we're diagnosing and kind of going through it. So it's autoimmune mediated, but that comes up in adulthood. So as most type 1 diabetes, I actually didn't even mention that it's autoimmune mediated, but the body's attacking itself, and therefore the pancreas cannot produce insulin because the cells that produce that secrete insulin have been attacked. Okay, so similar, it's an autoimmune mediated response, but instead of the response happening typically in childhood, it comes on in adulthood in our mid-20s or 30s.
We have another question here. This is an interesting one. Is shutting down, slowing down of fecal transit a symptom of diabetes?
Oh, a symptom. No, not a symptom of diabetes. It's very often we can see the two of them together, but not. There are some, like, when people have diabetes for many years, there is the nerves that innervate the GI tract. Those can be affected as well. So we can see that it affects our ability to digest food, but it's typically higher in the digestive tract. Not when I think of fecal transit, that's more of like a colon transition, but higher in the digestive tract, that's where we see it's called gastroparesis is one of the common things, but where the stomach won't let food leave, so it's stuck there. But again, that's like upper tract. So I'm not sure if I answered that fully.
Yeah, I think so. I think when it comes to diabetes or any other lifestyle disease like that, you're going to see a lot of things that are associated that come along for the ride, and it is associated with lifestyle decisions. You might see them together, but it doesn't necessarily mean, like, if you're not eating enough fiber, you're eating those highly processed foods, you might see higher blood sugar levels, and you might have problems with your digestion. Those two things might very well go together. It's an interesting thought. All right, so that is our time right there. So thank you so much, Dr. Cox. That was amazing.
Thank you all for coming. I hope you all have a wonderful, wonderful week. If you want to come for a stroll on Saturday, we have Walk with a Doc. Our topic's going to be high cholesterol. So if you are in the area and want to join us, it's at Ventura Pier, the base of the pier, 9 a.m. So great to see you all. Take care.
We're just going to share a few resources here. I have them up on the screen. We have our Dr. Megan Mescher-Cox and I created Disease Prevention or Reversal. We do these webinars the first Wednesday of every month. Remember, next month, we're going to be continuing this conversation with myself and a special guest. Dr. Megan Mescher-Cox has her website there that has information about Walk with the Doc the first Saturday of the month, 9 a.m. under the Ventura Pier. It's really fabulous. You get to walk and chat by the beach with some docs, so definitely check that out. And I also do a free plant chat every Saturday at 11 a.m. So, take advantage of these free resources. We love doing this, and feel free to reach out to us if you have any questions or if we can help in any way.
Take care.
Thank you, thank you, thank you, thank you. Have a great rest of your day, everyone.